So very warm good evening to one and all present here. Today, being a World Cancer Day, we have eminent speaker Dr. Satyaprakash Yadav to discuss on pediatric cancer care and how to improve the outcomes of cancer in children. So he has been known into the medical fraternity, especially in pediatrics, in treating young kids in Medanta. Thank you, doctor, for taking your time today and joining us. Over to you, doctor.
Oh, thank you, Soumya, for the kind introduction. So I would like to thank MedPiper and your group for inviting me for this important talk on this important day of World Cancer Day. And in today's endeavor, I will be speaking on childhood cancer. So let me share my screen with all of you. Just a moment. Okay, I hope you can see the screen now. So,
yes.
Yeah, thank you. So I will be speaking on childhood cancer, barriers and breakthroughs. And as you know, today being the World Cancer Day, so cancer is like one of the biggest problem India is facing, and globally it's one of the major killers. So in India, we have nearly about 500,000 to 600,000 people dying every year because of cancer. And this current COVID pandemic has killed around 500,000 people. So cancer is much bigger than this COVID pandemic and is killing every year so many people. And that's how it's a big problem, and we need to make it better, improve the outcomes for everyone, both adults and children. So I am a pediatric oncologist. I treat children with cancer, and I would try to give you an overview of where we stand in terms of childhood cancer and what are the outcomes, what are the common cancers, and how we can improve the outcomes. So first few slides will be the introduction about pediatric oncology. Then we'll discuss the barriers to cure, then discuss the solutions along with them, and then a little bit about common childhood cancers so that I can make you aware of what are the outcomes and how they are managed. And later on after the talk, we can take question and answers. We'll have enough time for that also. So this one picture is what describes what I do. So some see a hopeless end, while others see an endless hope. So this child, you see, his both eyes are practically out of his sockets. They're virtually dropping out of his eye sockets. And this child was at home for many, many months without treatment, and the tumor kept on growing and both the eyes came out. And finally, this child came to us for treatment. And it was horrific. Even in the hospital, the nurses, doctors, everyone was scared to see this kid, that it was such a horrific sight. And the family had given up all hopes. They felt that nothing can happen, this kid is going to die. And then we started the treatment, and his eyes went inside, his tumor melted away, and he has survived, although at a cost. He lost his vision, he can't see, but he's cured of cancer and he can live. So probably if he had got proper treatment at an earlier time, life would have been even better. He would have seen also, his vision would have been there. So we give hope and we give cure, and that's what we try to do for all children. That childhood cancer is curable if proper treatment is given. That's the key message to all the people who are logged in and listening to me. So how common is childhood cancer? If you look at the numbers, it's about 140 per million. So it's almost like in adult cancer comparison, it is nearly 1/10 of what the total cancer load is in the country. So nearly 1,400 adults per million get cancer. So children is 1/10 of that. So it's far less common in children, cancer. But out of every million population, 140 will get cancer. That means practically 1 in 10,000. So out of 10,000 people, one child will have cancer. Among all age groups, the commonest cancers are leukemia, blood cancer. So like the major work of pediatric oncologists is that we treat children with blood cancer. That's the commonest thing we do, because nearly 1/3 of total children with cancer are leukemia kids. They have blood cancer and we treat them. The second commonest is brain tumors. So it's nearly 20 to 25% of children have brain tumor. And third is lymphomas, which is about 15 to 20% of childhood cancer. And as children grow at different ages, they have different types of tumors. So like teenagers, when they're growing very fast, at that time, their bones are also growing very fast, and they tend to get bone tumors like osteosarcoma. And even Hodgkin's lymphoma is seen in prepubertal or teenagers. So 10 to 15 years of age is commonly you see Hodgkin's lymphoma. And very small children, like those who are infants, like less than 1 year old, there we see neuroblastoma. So what are the survival rates of childhood cancer? So if you see the top line, blue line, overall survival, 5 years of survival rate is about 83.9%. That means 84% of children survive. They are cured of cancer. They do well. So this is exact opposite of adult cancer patients. In adult cancers, if you are picked up early, you're diagnosed early stage, and you have proper surgery, radiotherapy, and a little bit of chemo and other things, you can survive and you can be cured of cancer. But if you're diagnosed late or your cancer has spread in adults, it's a doom and gloom. It's difficult to cure. You can only give them some time with the current medicines. So cure is rare in adults. It's just about 20% of adults with cancer are cured. 80% are not cured. They just get some time with treatment. In children, it is exact opposite. Majority of children, more than 80%, are cured for life. Their cancer is gone. They live a long life, and they are productive human beings, productive citizens of the country. So the main message you should take from my talk is that childhood cancer is highly curable. Unless proved otherwise, all children with cancer can be cured. Very rarely they are not cured. If you look at the various types of childhood cancers, acute lymphoblastic leukemia is the commonest, and it has the success is reaching 90% survival, which is fantastic. 50 years back, the survival was just 20 to 30%, and now it's 90%. Practically all children with acute lymphoblastic leukemia are getting cured. 90%, that's very high. Acute myeloid leukemia, not as good as lymphoid leukemia, but still 65% of them are getting cured. So nearly 2 out of 3 children are getting cured of AML, acute myeloid leukemia. Hodgkin's lymphoma, very high, 97% are cured. That's practically everybody is getting cured. Non-Hodgkin's lymphoma, 80% plus, bone and joint tumors, 70%. So you see the list. And at the end, there is kidney tumor, Wilms tumor, 93% are cured. So this gives you a very positive feed that majority of children are cured. But there's a hitch. And what's the hitch? The hitch is that this data is from USA, United States of America. Their SEER data, surveillance, epidemiology, and results data of children with cancer. And this is from the best of the best, where resources are not a problem, cost is not a huge problem, and everyone gets proper treatment. Now coming to India, where are we? So we are, I will start with this, that we are not in very good shape. So if 100 children are diagnosed or 100 children with cancer are in India, out of them, 30% or 30 out of 100 never reach a cancer center. They are never diagnosed properly. And they die before getting diagnosed in peripheral centers or villages and smaller centers. So just 70% reach the cancer centers or are diagnosed of cancer. And then another 20 to 25% abandon treatment. They are diagnosed and then they stop therapy because of various reasons we'll discuss in the coming slides. So finally, just about 50 to 55% of patients complete the treatment in India. And out of those who complete the treatment, about 50% are cured. So out of those 55 who have taken treatment, just 20 to 25 are cured. So overall survival in India is 20 to 25%. If there are 100 children, just 20 to 25% are cured. And that is exact opposite of West, where 84% are surviving in India, 24 to 25% are surviving. And this has to change. We have to make it better. And that's why I'm giving this talk, to make you all aware of this problem and how we can improve it. So what are the barriers to cure? Why children in India are not getting good outcomes? What are the barriers and what are the strategies or how we can change this? So Indian Pediatric Hematology Oncology Group had a brainstorming meeting a few years back, which we published, and we identified certain areas which I will take you through, and I will highlight what is being changed. So the first problem is delayed diagnosis and delayed referral. So most children are either not diagnosed ever, or even if they are diagnosed late and referred late to a cancer center. And this leads to problems. So the incidence of cancer in India is 38 to 124 per million. In West, it is 140 per million. In India, it's reported to be just 40 or 50 per million. Why? Because not all cancer patients are being counted or diagnosed. So many are undiagnosed. And if you don't diagnose, how can you count them? Especially rural India, the urban India, people still reach hospitals, are diagnosed, and they're accounted for. But rural India, because they don't have good hospitals and there are not good doctors available, they're never reaching big centers or never getting diagnosed. That's the problem. And when you're diagnosed late, your treatment outcomes are not as good as when you're diagnosed early. What are the major causes of this delay in diagnosis? First is insufficient political priority. So government doesn't have cancer as the priority thing, and there is no funding from government for childhood cancer. The main focus of government is on prevention of infections like pneumonia, diarrhea, malnutrition in children, because those are also important causes of death in childhood. Under 5 children, they either die of pneumonia or diarrhea very frequently in India, or malnutrition. So rightly, government is focused on that and they are spending a lot of money. But childhood cancer also needs funding and focus of the government, because if you don't provide good care, good funding, then 80% of them will die. That's what is happening right now. Then proper diagnosis and risk stratification. The cancer has to be diagnosed properly, then the proper treatment can be offered. So more than 50% of medical colleges did not have any facilities or expertise for treating children with cancer. So our premier medical colleges don't have a setup to treat children with cancer. They either go to a cancer center, or they go to adult medical oncologists or radiation oncologists, but there is no pediatric oncologist to treat children with cancer. They have never set up the facilities or the units and the system. Then the lack of diagnostic labs and centers. Like, we don't have MRIs available in all the medical colleges, or nuclear medicine, PET CT scans, etc., which are like sort of essential to diagnose and manage cancer or solid tumors. Then the lack of trained manpower and training in pediatric oncology. So in MBBS, the students are taught everything, or in pediatrics training, they are taught everything. But there is never a focus on treating childhood cancer, or preparing doctors that this is what you're going to see in your practice, and please learn it nicely and practice and take interest. They are taught that tuberculosis is a big problem in India. So learn how to manage tuberculosis, learn to manage infections, learn to manage brain problem, heart problem, and other things. But they are not told to focus on childhood cancer. And that's why when they become pediatricians, when they're working in their practice, they feel that childhood cancer is not curable, or we cannot do much because they are not confident, they haven't seen good outcomes in their medical college or during their training. Then socioeconomic and cultural factors. So there are limited financial resources. So cost is a huge barrier because cancer treatment is costly. So universal insurance is required. Patients need to have like Ayushman Bharat or something, some sort of a insurance cover. So with that, they can go to any medical facility where they can pay for their bills with that card from government and they have an insurance. So in India, we out-of-pocket expense is too much. We cannot make payment for these costly treatments from your own pocket. And that's where a big problem that many patients are scared to reach hospitals for cancer treatment, or they drop out soon after diagnosis. Ignorance. People feel that cancer is incurable, that anyway, even if we treat, it's not going to be cured. So why waste money? And then the girl child, that there is no point in treating a girl child. If it's a boy, then take the treatment. So distance from the medical center, that if you are from a village, then going to Delhi for treatment, or Bombay or Kolkata, staying in a big city, it's difficult for people. So these are some of the problems we have. So to summarize, the main thing is that we have to detect cancer early and then provide a proper treatment and good supportive care. That when you are giving chemotherapy, radiotherapy, surgery, the patient should not die of complications of these treatments. So that's where a good team or a good setup is required so that these children are well looked after. Then the second problem is the child is diagnosed with cancer and has started the treatment, but then the family stops the treatment, and that is known as treatment abandonment. So nearly 25, anywhere between 10 to 25% of children in India drop out. They abandon the treatment after being diagnosed and starting the treatment. We did some work, we published this paper where we looked at from week 0 to week 40, 50, till about a year from diagnosis, that how many children drop out of treatment. So the 90% plus children who dropped out, who stopped treatment, it happened in the first 4 weeks of diagnosis. So if you have continued your treatment for the first 1 month, then you are unlikely to drop out, because you have seen that your child has improved, his cancer symptoms have gone away, and child is feeling much better, and you have hope, you have met other patients, you have seen that it is curable, and you are better prepared. But in the first 1 week, family is very, very shaky. They have no faith in cancer treatment. They are scared of chemotherapy. People confuse them, relatives confuse them. They say, take Ayurvedic treatment, take homeopathic treatment, go here, go there, this is better, that is better. And you will spend a lot of money, and then they drop out of treatment. So abandonment has to stop. That's the biggest problem in India. And if we can ensure that all children take treatment, then outcomes will improve. So what happens to children who drop out? Do they all stop treatment and sit at home? No, we found that quite a number of them take treatment at some other center. So if someone came to a private hospital and cannot afford, they go to government like AIMS or Safdarjung Hospital or RML Hospital, Delhi. So go to government setup and take treatment there. So not everyone is sitting at home. Others, we found that they were taking Ayurvedic treatment, some were taking homeopathic treatment, and very few were doing nothing. They were just sitting at home. But majority of children who dropped out died, obviously. Then there comes the third problem. The third problem is infections. So acute myeloid leukemia is a very aggressive blood cancer, and it needs intensive chemotherapy to control this cancer. And when you give strong chemotherapy, your white cells are low for few weeks, 2 to 3 weeks. You have no white cells to fight bacteria or infections. And any infection can make you very, very sick, and you can drop your blood pressure, you can die if antibiotics are not given early, within 1 hour of getting fever. And that's where the problem is. Majority of children who have these leukemias, when they take strong chemotherapy, they are unable to reach hospital in time or get admitted because emergencies have crowds. The doctors are unable to see all the patients, and many of them die waiting for antibiotics or waiting for bed to get admitted. So that's the problem. bleeding. When they have low platelets, they can bleed and they need urgent platelets. They need a blood bank. So good supportive care is required, and that is lacking. And that's where nearly 15 to 20% of children are dying because of the treatment related toxicity or mortality or infections. And that's where we can easily improve that by providing better nursing care, better doctors, and better insurance, health care, so that they can go to any center which is nearby where they can take treatment. Coming to acute lymphoblastic leukemia, as I told you in the beginning, in the West, 90% of children are getting cured. What's the status in India? In India, about 50 to 60% of childhood acute lymphoblastic leukemia are getting cured. So we have improved, but we are not close to 90%, which is good. So again, in acute lymphoblastic leukemia, infections are a problem. Nearly 5 to 10% of children die of complications of chemotherapy within the first few months of treatment. And that can be easily improved by better supportive care or better training of the doctors and nursing and better, cleaner facility. So that's where funding is required. Then comes the treatment. So in West, they have used cooperative trials or groups are there. So there is a BFM group, Berlin, Frankfurt, Münster, BFM. 3 cities came together in Germany, and they started treating children on a uniform protocol for acute lymphoblastic leukemia. And that improved the survival from 30% to 90% over a period of 40 years. And they were treating all the children on a uniform protocol and then seeing how they are doing and analyzing after 3 to 5 years, and then making few changes and improving it further to improve the outcomes. In India, unfortunately, cooperative groups are lacking. We don't have uniform protocols to treat children with cancer. Right now, there is some heartening news. ICICLE trial is going on in India in about 15 centers for childhood blood cancer, and they are using a uniform protocol, and initial results are good, and hopefully the outcomes will be published maybe in March this year. And that's a good thing. But we need more for other cancers also. And we did a study long time back where we showed that in T lymphoblastic leukemia, if you give BFM 95 protocol, the survivals are very good. But if you use UKLL protocol, the relapse rates are very high. So you have to choose the right protocol and a uniform protocol and have to analyze the outcomes. If each center is treating in a different way, then they cannot analyze all the results together. So if 400 thousands of children are treated on a uniform protocol, and then we look at the outcomes, we can learn something that, okay, this protocol is good or not good, and we make changes and try to improve. So that's what is required. So then the last barrier is relapse. So you have treated a child, the family has taken the full treatment, and nearly 25 to 30% of childhood cancer patients, they relapse. The cancer comes back. And when they relapse, it's a hopeless situation. In India, hardly any centers encourage them for treatment. They tell them go home and it's incurable, nothing can be done. And relapse is a death sentence. But we have shown, and others in the West and in other centers in India, that relapse patients, nearly 50% of them can be cured. They can be retreated, but they need intensive treatment. They need high-end treatments like bone marrow transplant. So those are costly treatments and not available everywhere. So we have to make these treatments more accessible, available, affordable, like bone marrow transplants or immunotherapy or targeted therapies, newer therapies for relapsed patients. And we need to have some policies. Government has to provide funding, and we have to take interest that India has its own protocols, and we provide access for relapsed patients for newer and better treatments, and that would improve the outcomes. So these are the main areas where if we make changes, and we are making changes, that India is improving, but it will take possibly another decade for us to really improve further. We can easily improve outcomes to very good levels. I'm sure of that. And with coming, a lot of doctors, young doctors are getting trained. There are good training programs. Nurses are being trained. Medical colleges outcomes are improving. The better facilities are there. Ayushman Bharat is a big thing that There is insurance coverage available for many patients, and cancer is covered in Ayushman Bharat. So these are positive signs. Now we shift gears and we talk about leukemia, common childhood disorders. So typical leukemia, blood cancer, how does it present? So it presents with high white cell count commonly. So you do a CBC, a child will have TLC white cell count of 20,000, 30,000, 50,000, 100,000, or 200,000. And that alone may be the symptom, and the child may be getting high fever and other things. So always, whenever you have done a complete blood count, always look at the peripheral smear. You look at under microscope and look at the cancer cells if they are present, lymphoblast or myeloblasts. So if cancer cells are present, you have diagnosed the blood cancer. It's very easy to diagnose. So then there can be other problems. That child may have less hemoglobin, may be looking pale every day and becoming tired, lethargic, and that may be because of cancer. Or child may have low platelets and bruises or red spots or bleeding from anywhere. Or fever may not be going away. The child would be getting fever frequently for months altogether and not getting better. So maybe it's blood cancer. Joint pain or arthralgia can be a problem. The child may be having pains or swelling of joints and might present to pediatrician with those symptoms. Or it may be just low platelets. That's it. No other symptoms. Child may be very well and platelets are less than normal. So what are the various types of acute leukemia? Leukemia. So one is acute leukemia, which is acute. Acute means it develops within weeks to months. And if not treated, it's fatal. Acute leukemia is fatal. You will die of it within months. Chronic leukemia, on the other hand, is slow. It progresses over months to years. So even there is a delay in diagnosis or treatment, you can still live maybe for a year or many months. So in acute leukemia, there is acute lymphoblastic leukemia, acute myeloid leukemia, mixed phenotype leukemia. ALL is the commonest. 80% of children get acute lymphoblastic leukemia. And acute myeloid leukemia is 20%. And mixed phenotype is very, very low. Chronic is chronic myeloid leukemia, and juvenile myelomonocytic leukemia is what we see in children. So the outcomes, as I told you, in the Western world is approaching 90%, for ALL and AML about 60%. And in India, we are trying to improve and we are getting better with better facilities. So there are some common problems when a child it comes to you. So leukemia is not tuberculosis. I want to give a message to all the people who are attending this session that this 5-year-old girl, she presented with fever for a month and weight loss to the pediatrician. And he did a scan, X-ray, and found that there was a pot spine, the thoracic spine, the bone destruction, there is some mass, and he felt that it's a tuberculosis of spine. And he referred to the neurosurgeon for biopsy, and CBC was normal. And the neurosurgeon said that it looks like pot spine, there's no need of biopsy, and we can start anti-tubercular therapy. The patient was started on anti-tubercular therapy and dexamethasone and improved dramatically. The fever disappeared and the X-ray became normal. Child was very well. And then after 2 months, the dexamethasone was stopped and was shifted to 2-drug ATT. That child did very well. 4 months later, the child white cell count jumped to 100,000, platelets 40,000, hemoglobin dropped to 7, peripheral smears showed blasts, and he had leukemia. So initially, when the biopsy was not done, the child still had leukemia and was given steroids with ATT, and steroids melted away leukemia, and the child improved. But after some time, the steroid alone was not sufficient, so disease came back. So never give steroids without a biopsy. Unless you know what it is, don't give just blindly steroids and anti-tubercular treatment. Leukemia is not arthritis. An 11-year-old boy, Indian origin, presented in Sydney hospital with pain in the joint and swelling of the knee joint for a month. His CBC was normal, ESR was 40, there was no liver spleen, no other joints involved, ANA was negative, RA factor negative. So the rheumatologist in Sydney in the Children's Hospital gave intra-articular steroid, and there was dramatic relief. The swelling went away and the pain went away, and child was much better, doing very well. But just about a month later, the pain recurred. And now his CBC was all haywire. His White cells were 2000, very low. Platelets were 91,000. Peripheral smear was normal, but a bone marrow was done, and he had acute lymphoblastic leukemia. There were lymphoblasts in the bone marrow, and flow confirmed that it's a B cell type acute lymphoblastic leukemia. He came to India, got treatment, and is cured. But the message I want to give you that arthritis and arthralgia, you can never, don't give steroids unless you have done a bone marrow to rule out leukemia. So 20% of children of leukemia have rheumatological presentation of joint pain, joint swelling, and don't give steroids. Please never give methotrexate steroids without doing a bone marrow examination. Then always examine the testes in boys whenever they come to you with anemia or any problem where or fever is going on, or you have suspicion that this could be malignancy. You may find a testicular mass because leukemia can hide in the testes. And if there is a bulge there, and you can diagnose quickly that this may be leukemia. So always examine the child fully. Then sometimes children present with bulge in the eyes, as I showed you the first slide, the child with proptosis, and that can be a presentation of cancer. So this child, as you can see, the eye is just popping out. Both these two children, huge tumor pushing out the eye. And this is a retroorbital mass, that behind the eye there is a tumor, and that is pushing the eye out. And this is a solid form of acute myeloid leukemia called myeloid sarcoma. And diagnosis was made, and child was treated, and eye went inside. The other causes of proptosis in children are neuroblastoma. It can be a lymphoma. It can be Langerhans cell histiocytosis. There can be optic nerve glioma, sometimes retinoblastoma, rhabdomyosarcoma. So these are the various types. And good thing is most of them are curable with treatment. So if an eye is bulging out, always quickly reach a doctor and try to have a diagnosis, and early treatment will fix it and the vision will be preserved. Then coming to lymphoma. So lymphoma, there are typical presentations are painless swelling in the neck. So you will have a lymph node in the neck, which is there for many weeks and is not going away despite antibiotics and everything. There's no change. So always do a biopsy, excision biopsy of the lymph node, and that will give you a diagnosis of lymphoma. Other presentation could be breathing difficulty. The child may have a mediastinal mass in the chest. There is tumor sitting there and pressing on the trachea so that the child cannot breathe properly, or maybe compressing on the superior vena cava and causing the suffusion of the face and swelling of the face. And these children, if they lie down supine in the bed, they find it very difficult to lie down supine. They feel breathless because the trachea is compressed. So never ever give any sedation to these children because they will die on the table. If you give sedation, anesthesia, they will die on the anesthesia table. So avoid sedation in a child with a mass in the chest. Try to avoid a biopsy. If you do biopsy and there is bleeding, then the chest becomes tighter and the trachea is compressed further and the child cannot breathe. So this is a medical emergency. You have to start treatment quickly, and I will discuss this in the future in the further slides. Intestinal obstruction can be another presentation of lymphoma. Child having fever, high fever with weight loss can be a symptom of Hodgkin's lymphoma. It's called B symptoms, high fever and weight loss. Pleural effusions can be there because of lymphoma. Ascites, fluid in the stomach, can be because of lymphoma. Hodgkin's lymphoma, highly curable, as I told you, more than 90% of children are cured. Non-Hodgkin's lymphoma, 70 to 80% are cured. Burkitt's lymphoma. So John Burkitt was a doctor from UK who went to Africa, and he saw that a lot of patients, children were coming with a tumor of the jaw, and he did the biopsy. He saw it's a lymphoma. It's a new type of lymphoma, which he had never seen before. So it was called Burkitt's lymphoma. And he gave them cyclophosphamide chemotherapy, 1 dose, and the tumor melted. It disappeared. And then he called them for the 2nd dose, and the patients never came back. So many years later, 2 or 3 years later, they came for some other problem to the hospital, and he identified this is the same patient whom I had given chemotherapy, 1 dose. And he said, how's your cancer? And he found there's no cancer. So this is so sensitive to treatment that even 1 dose of chemotherapy can cure this cancer, Burkitt's lymphoma. So it's highly curable. And in non-African people, it presents with an abdominal mass, that there is a tumor in your stomach, not on your jaw. Anaplastic large cell lymphoma is another rare tumor which can be present with fever or hemophagocytosis. Lymphoblastic lymphoma can be T cell or B cell type. Then lymphoma is not tuberculosis. That's another message I want to give. So this child, 80-year-old, presented with this X-ray to a pediatrician, and he said, "Oh, it's a miliary tuberculosis. Child has fever, and this is the X-ray." He gave anti-tubercular treatment for 2 months. There was no response, and then child started having pain in the various joints and other things, and a lymph node was there. A biopsy was done. It was Hodgkin's lymphoma, and after treatment, it all cleared. All those shadows went away, those nodular shadows. So never ever give anti-tubercular treatment without having a correct diagnosis. It can be a Hodgkin's lymphoma. Lymphoma can have bone pains or bony lesions. So this child came with this X-ray. Can you see in the X-ray on the right-hand side, the second rib, there is expansile lytic lesion. The bone is expanded and there is a lytic lesion there. So Hodgkin's can rarely present with bony lesions, commonly seen in Langerhans cell histiocytosis, but Hodgkin's can also present, and bone pain also. A proper diagnosis took 5 months for this child to have a diagnosis of Hodgkin's lymphoma. Hodgkin's lymphoma typically has Reed-Sternberg cells. When classical Hodgkin's lymphoma, on the histopathology, these are the owl eye shaped cells which are visible. Then comes lymphoma, can be an emergency. T-cell lymphoma commonly presents with mediastinal mass, and that can have compression of the trachea, and there can be fluid in the chest, like this child you can see here. So in T-cell, in mediastinal mass, what you do is that you try to give steroids as soon as possible so that the mass shrinks and child becomes less breathless and more stable. If there is effusion, you put a needle and take out that fluid and send it to lab for flow cytometry, and you can diagnose lymphoma cells in the pleural fluid. But never give sedation, as I told you before. It can be dangerous. This is the mediastinal mass in the chest. You see no big nodes in the chest. Then surgical emergency. There can be intestinal obstruction because of Burkitt's lymphoma or lymphoblastic lymphoma in ileocecal region, and the surgeon may have to do a laparotomy to sort it out, fix it. Now, a little bit about solid tumors. So I'll finish in maybe another 5 to 7 minutes. So neuroblastoma is the commonest tumor in very young children, like those who are less than 5 years old. They tend to get neuroblastoma. And in very young children, less than 1 year old, it's very, very common. If you have a tumor in a child who's less than 1 year old, always think it could be neuroblastoma. Then when you do an X-ray of the tumor, there is always calcium deposit, calcification in that. So if a tumor is present and it has calcification, it's likely that it could be neuroblastoma. And you can do a simple urine test. There are certain chemicals which are secreted by neuroblastoma called vinyl mandelic acid or homovaleric acid, HVA and VMA. They are secreted in the urine. So you can send a spot urine test, about 30 ml of urine, to the lab where they can look for these acids, VMA and HVA, and if they're present in good quantity, then it's a neuroblastoma. You can have diagnosis straight away. And a PET CT scan is very handy. It can pick up the highly active tumor. So what is PET CT scan? It's a special type of CT scan where we give a radioactive glucose that is injected, and this goes and goes into the cancer cells. As cancer cells are very active, they use a lot of glucose, so they take up this radioactive glucose, FDG glucose, and then you take pictures and they shine like this. The red thing you see, that's the active tumor. So PET CT scan tells you how active is the tumor, and when you give chemotherapy, the redness should disappear, and that tells you tumor is dead or inactive after chemotherapy. So this technology is quite helpful, and it tells you, it's a whole body scan. It tells you where all the tumor is present. So neuroblastoma can be good, bad, and ugly. So good neuroblastoma is in very young children, less than 18 months of age. They are practically all of them are cured. And NMIC is not amplified. This is a genetic alteration. It's not amplified They do very well. If NMIC not amplified, young child, localized tumor, almost everybody is cured. A surgery is required. That's it. No chemotherapy required. If it's an intermediate risk tumor, then surgery and chemotherapy are required. But if it's a high risk tumor, that means NMIC is amplified or it has spread, it's a metastatic tumor, and the child is more than 18 months, then it has bad outcomes and difficult to cure. Just 30 to 40% can be cured. Sometimes it can present with paraparesis. It can compress your spinal cord because neuroblastoma arises from sympathetic chain, which is present along the vertebrae. And the tumor can be paravertebral mass and can enter the spine and can cause spinal cord compression, cause paraparesis, and affect the child lifelong, affect the quality of life. Then it can be an adrenal mass because sympathetic chain is present there, and retroperitoneal mass in the abdomen. So these high-risk neuroblastomas, they need transplant, radiotherapy, surgery, and anti-GD2 monoclonal antibody, which is not available in India, which can really improve their outcomes. Then Wilms tumor is the kidney tumor, and kidney tumor is usually incidentally detected by the mother while she's bathing the child. She feels in the stomach in the abdomen there is some palpable hard mass, and she goes to the doctor. They do an ultrasound. They find that there is a tumor in the kidney. So it's picked up only when the tumor is very big. Then you can easily feel it. And usually they are asymptomatic. Sometimes they can have blood in the urine, red urine can be there. That can be an indication it can be kidney tumor. It's highly curable. As I told you, more than 93% of them are cured with the current treatment. Even if there is metastasis, it has spread to lungs and all, still it is curable. So it is highly curable. Liver tumors, usually in very young children, there is hepatoblastoma, and it can be diagnosed with an ultrasound, and you check for tumor marker called alpha fetoprotein. So you do a blood test, and if alpha protein levels are high, that tells that it could be a liver tumor. And in older children, it can be hepatocellular carcinoma, like those who are more than 10-year-old. It can be hepatocellular carcinoma after hepatitis B or hepatitis C infection. Rhabdomyosarcoma is a tumor arising from muscles. It is commonly seen in head and neck area and genitourinary tract. So this tumor has some favorable sites like orbit. If it's present in the eye, it's highly, highly curable. If it's present in the genitourinary tract, but not in bladder or prostate, it is very, very curable. If it has spread, then the cure rates are low and it's difficult to manage. It needs intensive radiation, chemotherapy, and all the other treatments and surgery. It can present in calf muscle like this boy. There's a tumor in the leg. It's called alveolar rhabdomyosarcoma. Alveolar has poorer outcomes as compared to embryonal rhabdomyosarcoma. Now, last but not the least is the brain tumor. So in India, brain tumor outcomes are not good, to say the least, because brain tumors need multi-speciality care. There are various teams have to work together. So one is, first they need imaging, CT scan, MRI. Then they need a neurosurgeon to do a surgery to remove the tumor. And after that, they need a radiation oncologist to see if radiation is required. And they need a pediatric oncologist if chemotherapy is required. And they all need to sit down together to discuss what is the best plan for that particular child. And that is not happening. And that's why Indian Academy of Pediatrics brought some guidelines and to help people to diagnose and treat brain tumors in a proper way. So this is a tumor astrocytoma in the brain, and where if it's a low grade, surgery alone is sufficient, but if it's high grade, then the outcomes are bad and they need radiation and chemotherapy. This is a tumor which is present in the posterior fossa and has spinal metastasis. This is a medulloblastoma. Medulloblastoma is highly curable with chemotherapy and radiotherapy. So here, there are average risk and high risk. Average risk are those where the tumor has not spread to the spine and the CSF is clear and the tumor has been nearly removed totally by the neurosurgeon. Then they have very good outcomes. Nearly 80% of them can be cured. But if there is residual tumor, despite surgery, a lot of tumor is remaining, or if the CSF has cancer cells, or there are spinal metastasis, those children do poorly. And age is also a matter, that those who are aged more than 3 years, they do better. Less than 3 years, they do worse. Then spinal cord tumors can be there, like this ependymoma, and that can cause urinary and bladder bowel problems and paraparesis. And as I told you, there are certain tumors which can be present outside the spine and compress the spine, like neuroblastoma, Ewing sarcoma, lymphomas, and it's a medical emergency. Whenever there is spinal cord compression, the surgery has to be done quickly. A neurosurgeon has to go in and release the pressure so that the limbs can be saved. So I'm nearly done, and this is the last slide. So what's new, or what is the future of oncology? So this was the Time magazine cover way back, I think in about 2000 something, that we have a new ammunition in the war against cancer. These are called the bullets. So targeted therapy came for a disease called chronic myeloid leukemia. So CML was uniformly fatal and could not be cured. But in 2000, a medicine was developed called imatinib, and that medicine blocks tyrosine kinase enzyme, which is driving this cell growth of the chronic myeloid leukemia. And if you block this tyrosine kinase, BCR-ABL to be exact, fusion gene, which is blocked by this medicine, then the cancer stops growing and the CML goes into molecular remission. And these patients who are taking these tablets now for nearly last 20, 25 years, they are disease-free with just a pill. They have not taken any chemotherapy, no transplant, nothing, and they're doing very well. So this particular disease, chronic myeloid leukemia, has shown that if you find the right targeted therapy for a cancer, it can become very easy to control the cancer or cure the cancer, and your life, you can live a long and normal life, and it's a magic. So we are trying to find more and more targeted therapies so that more and more cancers, we can stop giving chemotherapy and just give the right targeted therapy, which will have less side effects. Other new thing, which is this girl you see in this picture, she's Emily Whitehead. So Emily Whitehead had acute lymphoblastic leukemia, and she was being treated in Children's Hospital, Philadelphia, US. She had relapsed 3 times, had 2 bone marrow transplants. And then the doctor said, your acute lymphoblastic leukemia is incurable. We cannot cure you, and we can't do anything. Her father did not give up. She was just 5 or 6 years old at that time. And father said, is there any new research going on, any new treatment people are trying to figure out cancer, acute lymphoblastic leukemia? So Dr. Steve Grubb, who was treating oncologists, he said there is a certain doctor called Dr. Carl June, and he has a treatment which he has successfully tested in mice, where he can clear cancer within 24 hours. So you can meet him and understand this treatment. So father went to Dr. Carl June and he said, what is this treatment? And can my daughter get this treatment? Carl June said, yes, this treatment works. We have tested in mice and it is doable in humans. We can do it, but I have no funding. I have no money to do this research trial and do this treatment. So his father said, okay, I'll raise the funds and I want my daughter to be the first patient for this new treatment. And what was this treatment? This was a magical treatment called cell therapy. So they took out Emily Whitehead's lymphocytes, T lymphocytes, her immune cells, and then genetically modified those immune cells in the lab so that they could target CD19 protein on the cancer, on the blood cancer. There is a protein called CD19. So they genetically modified her immune cells so that they can kill CD19 positive cancer. Then they put those cancer cells back into her 24 hours later. And as soon as those cells went in, they started killing the cancer. And all her cancer disappeared in 24 hours. She became cancer-free because those immune cells killed the cancer. But she got very high fever. She became very sick. She landed up in ICU. She went on ventilator because there were a lot of chemicals released and she was very, very unwell. Inflammation was there. They gave anti-inflammatory medicines, certain injections, and inflammation came under control. She came out of ventilator. And today, 10 years later, she's cured of cancer. And those genetically modified T cells which were put inside her are still living. They're still alive. They're still working in 2022. It was done in 2012, 10 years later. So this is known as a living drug. FDA has approved it as a drug, cell therapy, and it's called a living drug, which is alive and working. So this is something magical which has happened in oncology, that in future, we will have cell therapy for various cancers. Acute lymphoblastic leukemia is the first disease where it's available. And now it's applicable to lymphomas also. And in future, it may be for other cancers and where we can magically cure them with cell therapy. So I will finish here. This was my last slide to give you all hope that cancer or chemotherapy-free treatments would be possible in the future with targeted therapies and cell therapies. And in India, CAR T cell therapy trial has started in Tata Hospital in Mumbai. So it's available in India also now. And it's a matter of time that it would be available at many centers in India. Thank you. I'll finish here and I'm happy to take questions.
Thank you, doctor.
Thank you.
We have a couple of questions.
Okay. So I should read those. There are some in the chat box. So Dr. Bharat Parmar, he is asking, is there presentation of thrombocytosis in acute lymphoblastic leukemia? Okay, so that's a great question. Usually not. In acute lymphoblastic leukemia, platelets are normal or low. But some cancers can have high platelets, or if there is some inflammation going on or some infection in the chest or infection in the brain, then platelets can increase. So the cancer causing high platelets is known as essential thrombocytosis. That usually happens in adult patients, but rarely I have seen in my career just 2 children who had essential thrombocytosis where their platelets were high because of myeloproliferative disorder or a chronic leukemia. So it can happen, rare, but ALL doesn't lead to high platelets. Then there is a second question by Amrita. She has asked, good evening, sir. My question is it possible to induce a loss of function mutation in cancer cells so that it doesn't pass on to the next generation? Okay, so in general, cancers are not hereditary. So like acute lymphoblastic leukemia, if it happens in the one child, it will not happen in the next child. In my entire career, I've never seen 2 children of the same family getting acute lymphoblastic leukemia. But certain tumors like retinoblastoma can be hereditary. So father may be having eye tumor retinoblastoma and his children can also, he can pass on that gene and children can also get retinoblastoma. So yes, in these cancers which are hereditary, it may help to provide this type of treatment where you can cause some mutation and cause loss of function of these particular gene. So it may be helpful, but this work, I think it needs research. So I'm not the right person to answer further on this topic. Then Dr. Bharat has asked, is there presentation of hypertension in Wilms tumor? Yes. Wilms tumor, it's a kidney tumor. Blood pressure can sometimes be high, and you should always measure the blood pressure in a child with kidney tumor. Neuroblastoma is another tumor where there can be hypertension, and sometimes pheochromocytoma can have high blood pressure, and it can be extremely high in pheochromocytoma. It's a medical emergency to control the blood pressure. So I think these were the questions, and any other questions are there, I can take in the chat box. I think there's some more. So there is one question, how can you reduce the risk of childhood cancer? So why childhood cancer happens? So there are not many answers for that, but there are certain hypotheses and some research has been done. For acute lymphoblastic leukemia, there is some work done in UK, especially in precursor B cell type acute lymphoblastic leukemia. They found that those children who don't go to daycare or childcare in the early childhood and stay at home, they are more likely to get childhood cancer, acute lymphoblastic leukemia, than the children who go to the daycare. So he proposed that those who get a lot of viral infections in the early childhood, in the first 3 years of life, their immune system, B lymphocytes, get fine-tuned to work normally, and they don't get B cell leukemia. But if your immune cells are not exposed to viruses in the early childhood, then these B cells are not perfect, and they can convert into B cell leukemia when they're exposed to infections later on in the childhood. So usually B cell leukemia happens in healthy children who have been very healthy in the first 5 or 10 years of their lives. They get it. So that is one thing. Epstein-Barr virus is known to cause 90% of Hodgkin's lymphoma. So this virus causes Hodgkin's lymphoma. It causes some other cancers also. Then human papilloma virus is known to cause cervical cancer. So there are certain viruses which can cause cancers. But we don't know about all the cancers, how they happen. And there are certain genetic predispositions like Leaf-Romani syndrome, where there is TP53 gene mutation, which is hereditary, and they tend to get different kinds of cancer in various family members like sarcomas, bone tumors, leukemia, etc. And there is BRCA gene, which can predispose to breast cancer and ovarian cancer, and can run in the families. Then there is a question by Shri Renj, and are organic pesticides associated with cancer? So that's a great question. In general, whichever country has industrialized, the cancer rates have gone up. Like in 1940s, it happened in UK and US. In 1950s, it happened in Japan. In 1990s, it's happening in China and India. Because we are industrializing, we are using a lot of chemicals and construction, pesticides. So possibly yes, but I don't know which particular pesticide causes it. So more research is required, but possibly there can be link between pesticides and cancer. So that was
I have a question.
Yes, tell me.
Yeah. So is there any like common like tyrosine kinase or MAPK inhibitor? Like has any drug been developed like that to prevent excessive cell division?
So there is something known as oncogene addiction. So oncogene addiction is that a cancer, if it's dependent on a particular gene which is driving that cancer, then if we block it, we can cure it. So CML has an oncogene addiction for BCR-ABL. It has a gene called BCR-ABL, and the growth of the cancer is solely dependent on that. And with imatinib, we block it, and the CML is cured or controlled. But in acute lymphoblastic leukemia, there are multiple pathways. So there is not just one pathway. So it's not dependent, it's not addicted to just one gene. There are multiple pathways, multiple genes. So you block one and the cancer can still grow. So it's you are unable to block it completely. So that's the problem in many cancers, that they are not just dependent on one cancer, and they are multiple pathways. So they may need multiple targeted therapies, or immunotherapy, or cell therapy, or antibody therapy. So we have to find the right combination. That work is going on, and you're right. There are a lot of other inhibitors have come in the market, and there are a lot of research is going on. But we are trying to figure out that how to combine them with chemotherapy and other agents so that there is more success.
So each cancer has a separate pathway, right, for progression?
Yes. So I'm saying that some cancers are dependent on just one pathway. In them, targeted therapies can be very effective. So like a glioma in the brain, many of them have BRAF mutation. So if that is present, their BRAF inhibitor is available, and you give that, and the tumor would shrink and they would respond beautifully. But glioblastoma multiforme is dependent on multiple pathways, and you cannot block one and still you cannot control it, and most patients die. Nothing works. So we need to find another approach to cure them.
Thank you.
Thanks. So I think any other questions, Soumya, if there is anyone has any other questions? I'll just see in the chat box if there is anything more. Yeah, so I think nothing more is there. So we can finish. It's another 3 minutes are remaining. So my message again to all the audience is that it is highly curable childhood cancer, and that's the message you should spread in the community. And people should go to the hospital, get diagnosis, and get proper treatment. And with that, their children can be cured and live a long and healthy life. And that's the goal. And on this World Cancer Day, I hope we all make a difference by raising awareness and promoting good health amongst children so that they don't get cancer. And if they get cancer, they are cured. Thank you.
Thank you, Doctor. Indeed, it was a great session in explaining various conditions of childhood cancer and what are the things we need to be careful of when a kid is diagnosed with cancer. I have one small question with you. We have been treating younger patients for quite some time. And I always see there is some sort of difference in your treatment style. Can you just tell us like how differently, what changed you to that kind of style, and maybe some sort of advice to the young pediatricians in the country right now?
So you're asking that very young, like infants, if they get cancer, how they do, or what is the difference? That's what you're asking me?
Yes.
So infants, in general, they don't tolerate chemotherapy very well. So it's too strong for them. So very young child, like 2-month-old or 1-month-old, 3-month-old, it's difficult to treat them. It's quite a challenge. So if a very young child gets blood cancer, always look for Down syndrome, because Down syndrome children, they are mentally like little slow. But the good thing is that their blood cancer can be temporary and it may disappear on its own. So they don't need chemotherapy. So if the child has Down syndrome and is diagnosed with blood cancer, and it's very young, like 2-3 months old, just leave him alone. Don't give any chemotherapy. The cancer will disappear in majority of the cases. So that's one thing pediatrician should know, that if Down syndrome, then there is no hurry to give chemotherapy. Neuroblastoma, if diagnosed in a neonate or antenatally, mother's womb, they do an ultrasound, they find the child has a tumor and it's a neuroblastoma, then there is no need to treat. Just observe. Most of them disappear on their own. So newborns born with neuroblastoma don't need any surgery, don't need any chemotherapy. Their tumor just disappears on its own. So these are the exceptions in very young children where you just don't give any treatment and the cancer disappears. While other children who get rhabdomyosarcoma or get some other tumors in early child, brain tumor, they don't do well, and they don't respond to treatment very well and are difficult to cure. Infants with leukemia, they need more intensive treatment, and their disease is more aggressive, infant blood cancer, acute lymphoblastic leukemia in infants. So thank you. Any other questions?
Doctor, I think we have taken up all the questions, and if I am getting any more questions regarding to this topic, I will forward to you. And once again, on behalf of MedPiper Technologies and JournoMed, thank you so much, Doctor, for joining us today on a Friday evening. Looking forward for more collaborations and in the pediatric cancer care aspects, and we thank you and looking forward to see you soon. Thank you.
Thank you, Soumya. Thank you, MedPiper, and thanks to all the audience who have been patiently listening. Thank you. Have a good night.